Good afternoon, ladies and gentlemen, on a beautiful Friday afternoon in Paris. I greatly appreciate so many people staying for this very important special lecture, which I think is a wonderful end to a fantastic day at this outstanding meeting. It's my first COMy, and I think it's been a real treat. So I especially applaud Mohammed, Arnon and Thierry for a fantastic setup and all of the organizing team. Mohammed asked me to chair this session, and it's a distinct privilege because having treated my first myeloma patient in 1986 and having been mentored by a wonderful man, the late great Tim McElwain, who was with Ray Powell's the first to publish in the area of high-dose melphalan in The Lancet in about 1983, as I recall. Of course, the person who has really led the charge with high-dose therapy and transplantation in myeloma is no one less than, of course, Bart Barlogie. And Bart is arguably a true visionary who approached the disease with the head of a leukemologist and the spirit of a leukemologist, and above all, someone who deeply cares for his patients. And I think that is something that I've seen myself, and in the patients Bart and I have shared, has been a uniform report from them as to how much he's cared about them. And I think that's a remarkable thing for people to share about an outstanding clinician, researcher, and scientist. Bart, of course, headed the Myeloma Institute at the University of Arkansas, which has been a powerhouse behind the concept of total therapy for the last 30 years. More recently, he's transitioned to Mount Sinai in New York with Sundar Jagannath and Achai Chari and other outstanding colleagues at Mount Sinai, and is already making a big difference there. Under his leadership, I think arguably the concept of multiple myeloma as becoming a curable disease in younger patients actually has become, for a key subset, a functional reality. And this total therapy approach, I would argue, is something we've all embraced in different ways, using all the active agents early in the disease, followed then by some form of cellular reboot, be it with melphalan, as we were just discussing, to something now in the future arguably perhaps different. But nonetheless, the concept of consolidation and maintenance, all of these have been very much led and championed by Bart. So it's a tremendous honor and privilege for me to introduce Dr. Bart Barlogie to give a special lecture on total therapy and update. Bart, thank you very much.
Merci beaucoup, mes amis.
Enchanté.
Thank you. So what bothered me when I entered the myeloma field from acute leukemia was that palliation was the only possibility, but I also sensed a resistance, if you will, in thinking of myeloma as making it a disease where complete remissions ought to be achieved and where one could aim at cure, because if you don't make this an objective, it won't ever happen. So it was very clear from the outset that myeloma was heterogeneous, which we now understand better at the genetic level. And it gives me a pleasure to give you an update on the total therapy trials. Started off with total therapy 1 when Sundar Jagannath joined me from the MD Anderson in Houston to Little Rock. And we had performed a tandem transplant program in relapsed refractory myeloma, where the CR rate, especially with the use of peripheral blood stem cells, had been increased markedly. So we felt comfortable testing this in newly diagnosed patient, and the consent form indicated, believe it or not, that cure was the objective. It was a phase 2 study. I'm still amazed how patients actually bought into this, you know, saying, well, you get all of this treatment as delineated under TT1, and those who enrolled actually stuck with it for the most part. In total therapy 2, we asked a question about randomization of thalidomide once its value in relapse refractory disease had become apparent. And we also introduced in this trial consolidation chemotherapy with DPACE, which we carried over into total therapy 3, where we also used bortezomib upfront and in maintenance, as you see. So these are data as of, I believe, early 2015, and the flatness of the curves are readily apparent. Progression-free survival on your top right, complete remission duration on the middle of the right. And all of these data actually have been verified because patients would come back to Arkansas on an annual basis. So this is all real data. They are not any censored observations, which I think is very important as one wants to talk about curability. And many of the novel agent combinations, I think, lead to go out 5-7 years, but then I think there's also lack of support to follow these patients in the long run, and maybe industry can be convinced to finance some of this follow-up cost. This point I want to make is that there are patients, as we discussed earlier, who don't achieve complete remission, let alone stringently defined complete remission, and yet they can have prolonged progression-free survival, albeit at a lower level. We now know these are mainly patients who have the CD2 molecular subtype characterized by an 11-14 translocation and co-expression of CD20. They typically have a much lower CR rate, but they have a more durable progression-free survival than, for instance, these CD1 subtype without the CD20 expression. Dr. Crowley and his colleagues in Seattle modeled our data for the publication in Blood, addressing the curability of the disease. And you can see that the experimental data and the computer estimates are consistent with cure, whether one looks at progression-free survival or at complete remission duration. And you can see that while the more recent studies lack the longer follow-up, but it's very difficult to imagine that their tail will be lower. And when one looks at a 5-year landmark shown on the bottom, then this point, I think, becomes very clear. We started doing gene expression profiling halfway through total therapy 2, which accrued 668 patients, and Dr. Shaughnessy, when he was with us, introduced this. On your left, you see that patients with low-risk disease, applying to 85% of patients, achieved a plateau that took about 10 to 12 years to reach. And with the introduction of thalidomide in total therapy 2 and the addition of bortezomib in total therapy 3, you see this very marked improvement. On your right, the outcome for patients with high-risk disease defined by the 70 gene model, you see there's very little difference in the median progression-free survival, but a plateau actually does develop, and typically at an earlier time, like 5 years or so into the observation. And I feel very comfortable telling a patient who presents with high-risk myeloma defined by gene expression profiling, when there's no recurrence 5 years or 6 years into the clinical course, that such event will be very rare, very similar to high-grade lymphoma. So I think, from my perspective at least, having had the very long follow-up, and that is absolutely crucial. I'm following some of the total therapy 1 patients in New York, and some have reached 23, 25 years and are documented also at the MRD level to continue in complete remission. So I like to think that we ought to talk about myeloma as a disease that can be cured, so that patients actually have the benefit of looking forward to the state instead of harping about the fact that it's an incurable neoplasm. So, in my view, the follow-up of novel agent trials is too short to determine curability, and by the same token, although the short-term follow-up is relatively limited, and the CR rates with, let us say, CRD may exceed what has been accomplished even with a tandem transplant approach, we don't know whether all CRs were created equal. And it's conceivable that melphalan, as the Kalashnikov approach that has not been well studied at the molecular level in terms of effects on the tumor cells as well as the bone marrow microenvironment, may actually do wonderful things that we don't appreciate at this time, and may be responsible for the durability of remissions. Therefore, I think we are not at a point, at least I'm not at a point, to abandon the transplant approach, and I will come to how to go about this in the future. We did have the opportunity to study MRD at a level of 10 to the -4 in our program that we got established with the help of Bruno's. And the data indicated that the MRD percentage in low and high-risk disease doesn't differ. The hypothesis that my colleague Fritz Van Drie had put forth was perhaps the MRD level is less in high-risk disease, and it may be if one uses more sensitive technology, and I think that's important to investigate. Well, as we recognized that genomically defined high-risk disease, those 15% of patients had not benefited from our successive trials. We then decided 5 years ago or so to give total therapy 5 to patients with high-risk disease, and total therapy 5 emphasized a dose-dense but less dose-intense program, because we had seen that relapses with the preceding total therapy approaches in high-risk disease occurred at any treatment-free interval between first and second induction and transplant, transplant 1 to transplant 2, and so on. And in low-risk disease, we decided to look at reducing the frequency of induction and consolidation therapy from 2 to 1 cycle each, and applied melphalan in fractionated dosing of 50 milligram per meter squared times 4 with the addition of bortezomib, something that the IFM is investigating based on some earlier trials, I think, that Jean-Luc Arrousseau had pursued and reported on. Results of total therapy 4 are shown here. For the standard arm in blue and for the light version in red. And it was very peculiar for us to note that while with the standard arm we saw an independent importance of the presence of metaphase cytogenetic abnormalities that we had seen with the predecessor trials, total therapy 1 and 2 and 3, we noted that the presence in low-risk disease of metaphase karyotypic abnormalities was unfavorable. In the case of the light arm, for some reason, this was sort of reversed, and it's not understood, and a paper is in preparation to address this. But you can see, maybe due to the addition of bortezomib into the transplant regimen with melphalan, those patients did better. Total therapy 5 for high-risk disease was absolutely no progress. You can see overall and progression-free survival were superimposable. Complete remission duration was actually inferior because we did not apply consolidation chemotherapy. We used induction, transplant 1, then intertransplant trials with consolidation chemotherapy, then the second transplant, but no further consolidation therapy. We did look, as in previous studies, at the value of PET scanning, and this slide shows on the bottom right that those patients who had normalization of focal lesion presence on day 7 actually had a better outcome, reaching that almost of patients who had no focal lesions prior to therapy. So where do we go from here? Both progression and overall survival duration with total therapy in high-risk disease are on the order of 2 to 2.5 years only. So if one wants to discover something novel, this is the group of patients where this could be done, and if positive, then one can gradually introduce such non-transplant approach also for low-risk disease. We have been trying to look at surrogates for cure, including gene expression profiling. This was part of the blood paper that we published looking at gene expression profiling of the whole bone marrow biopsy. And when patients achieved a state that was comparable to age and sex-matched normal controls, those patients had a superior outcome. We had noted that the difference between MGUS and myeloma really resided mainly in the bone marrow microenvironmental signature. So one could argue and investigate whether normalization of the bone marrow microenvironment beyond just the MRD level would be a good surrogate to predict long-term outcome. This is a patient originally from New York who followed me. He's been out for 12 years. 5 years into his disease, he developed extramedullary disease in the liver. We applied hepatic artery infusion chemotherapy with etoposide, adriamycin, and Ara-C, and hydrocortisone, and he got such treatment on 3 or 4 occasions, along with chemo with embolization. He was the second patient in whom we got exome sequencing data performed by Foundation Medicine, and he had a RAS mutation. So he then got trametinib, single agent, 2 milligram daily, and amazingly, within a month of starting, he entered complete remission of this extramedullary disease. That was more surprising to me than even the thalidomide observation that we made in a patient who had 4 transplants and who was had a packed marrow and was transfusion dependent for red blood cells and platelets. This was quite stunning. He then developed a drop in the ejection fraction. I stopped the treatment, and he did relapse within 4 or 5 months. Retreatment did not work, and he is currently on combinations of daratumumab, carfilzomib in high doses, and nivolumab as an immune checkpoint inhibitor. And I just got earlier an email from Mount Sinai that his proBNP had reached a level of 20,000 while on weekly carfilzomib at 70 milligram per meter squared. So you have to be careful. All right? Christoph Heug, who was with us, put these data together. They are published. And here is a waterfall plot of patients receiving trametinib alone and in combination. And the drug clearly has a role to play, and especially as exemplified in this patient I showed earlier. Here is a patient who got the PD-L1 monoclonal antibody nivolumab, and he had been previously on pomalidomide and trametinib. And upon the addition of nivolumab, he achieved a marked response by PET scanning. We had previously reported in relapse refractory myeloma, this was done, work published by Xenophon Papanikolaou from Athens, Greece, that this low-dose continuous infusion approach, which works through an anti-angiogenic mechanism, was effective, especially effective in patients who had limited bone marrow reserve. So the patients could tolerate, even while thrombocytopenic at a level of 20,000, with further aggravation of thrombocytopenia, this metronomic therapy consisting of in this study of 28-day continuous infusions of doxorubicin and cisplatin, both at 1 milligram per meter squared, with the addition of VTD. And this I applied then as we learned about the dismal results with total therapy 5 in high-risk disease. I applied this approach in a patient with impaired cardiopulmonary function, and this patient entered complete remission within 6 weeks of starting. I did not want to prejudge the efficacy and the long-term disease control, so I held further therapy. The patient then had had a relapse by 8 months, and she followed me to Mount Sinai from San Antonio, and she is currently on nivolumab therapy and doing well. Here you can see on the bottom right that actually at the end of such therapy, sometimes the GEP-defined risk lowered from high to low risk. We had previously only seen the opposite, that low risk only can get worse. but here you actually can see the converse. When looking at the angiogenesis, we did see that the CD34 expression decreased, and the regimen details are delineated here on the bottom. And I think I'm ending on time. I want to thank patients for their courage and endurance, the referring physicians who entrusted us with taking care of their patients, past and current colleagues, financial support, and I'm always grateful to my wonderful mentor, Jay Freireich, who still goes to the office 5 days a week at age 90. Thank you very much.